Hello everybody, Dr. Ryan here. I'm a board-certified specialist physician. Thank you so much for joining me. It means we talk about Behcet syndrome today. If you haven't yet subscribed to my channel, I strongly encourage you to smash the subscribe button, like and share. Thank you so much. I truly appreciate your support on this platform. So we've got a 33-year-old Iranian man coming in for investigation today of a 6-month history of a couple of things: general malaise, weight loss, and he's got what looks like arthritis, pain in his knees, ankles, wrists, together with fever, sore mouth. On systemic inquiry, he gave a two-year history of recurrent sores in the mouth, which makes it difficult to eat. Sorry for the typo there. Just before the onset of all of his symptoms, he had experienced an attack of abdominal pain and bloody diarrhea, which resolved after a week. He was seen by a gastroenterologist shortly afterwards, who diagnosed an inflammatory colitis, possibly secondary to infection. Rectal biopsy performed, and it was reported histologically as non-specific colitis. The patient has never experienced any abdominal symptoms after this, but had several episodes of soreness affecting the mouth. In addition, he developed painful eyes and pain on intercourse, which is dyspareunia, and on voiding urine. So he has dysuria. There is no history of erythroid discharge. Shortly afterwards, he was admitted to hospital with a femoral vein thrombus, oh man, which was treated with anticoagulation and thought to be secondary to dehydration and immobility from the diarrhea. During the past 6 weeks, his health has gotten worse. He has arthralgia and fever. He's been married 5 years, denies any extramarital encounters. His wife was well and has not experienced any similar symptoms. Now, on exam, the patient appears relatively unwell. Examination of the oral cavity. I'm going to show you a couple of slides coming up. He had submandibular lymphadenopathy. His ankle, wrist, and knee joints were tender, joint movements restricted. In addition, he had painful lesions on his legs. Examination of anal area as well as abnormal. He also pointed out a lesion approximately 2 centimeters in diameter that has developed at the site of a venipuncture during a blood test, which is pathology, right? All other aspects of physical exam are shown. Okay, so this, let me get my pen in here. So we've got a couple of nice images here. So this is definitely an aphthous oral ulcer, and these are anal ulcers, right? This is conjunctivitis, a differential for a red eye, and the beautiful shin lesions, which represents panniculitis, which is erythema nodosum. Looking at his blood results, he's got a significant anemia of 9.8, which is normocytic because the MCV is 82. White cells, leukocytosis, white cell count 13. Platelets also slightly up. Importantly, rheumatoid factor, anti-nuclear factor negative, and radiology of the joints are normal. What's going on, guys? What's the most likely diagnosis? Is it Crohn's disease, ulcerative colitis, Wright's syndrome, Behcet, or gonococcal septicemia? And the answer is Behcet syndromes. Whether you say Behcet, whether you say Behcet, same thing, Behcet syndrome. So this patient has a conglomeration of oral and anal ulcers, conjunctivitis, arthritis, and the infamous erythema nodosum, together with features of some kind of systemic illness. There has been a single episode of bloody diarrhea and a previous femoral vein thrombus for which he was anticoagulated, making Behcet syndrome trump diagnosis, right? What is Behcet's? It is a recurrent multifocal disorder that persists over many years. Characterized, the big sellers for Behcet, which patient should you think may have Behcet syndrome is one who has recurrent mouth and genital ulcers, number 1, ocular lesions, number 2, skin, joint, and neurological involvement, numbers 3, 4, and 5. The incidence is very high in Japan and along the Silk Route, which is in the countries bordering the Mediterranean. Oral and genital ulcers are present in most patients. Ulcers can affect the pharynx and cause dysphagia, can also cause dysuria and dyspareunia, as we see in this particular case. Ocular lesions are the most serious because they can actually become sight-threatening, right? Recurrent uveitis, iridocyclitis, retinal vascular lesions, optic atrophy, you name it. Erythema nodosum is a recognized feature. Other skin manifestations include diffuse rash affecting the face with erythema multiforme. Sorry for the typo there. Pathology, as we said, is a very useful diagnostic sign. So this is a beautiful pathogenesis slide taken from the Calgary Guide, a beautiful resource, right? And essentially, a couple of risk factors for erythema nodosum, like genetic dysregulation, infections like strep pharyngitis, medications like contraceptives, sulfur drugs, malignancy like lymphoma, autoimmune conditions like sarcoidosis, inflammatory bowel disease, pregnancy. So all these antigenic stimuli or bacteria, viruses, or chemical agents could trigger the following 6-phase process. In phase 1, the neutrophils infiltrate the fibrous septa between the fat globules and the subcutaneous fat. So just remember the different layers of the skin. From outgoing in, we have the epidermis, then we have the dermal-epidermal junction, the dermal layer, the subcutaneous fat, and then we have this area here, and subcutaneous fat. So neutrophils infiltrate these fibrous septa. Phase 2 is where the neutrophils release reactive oxygen species, leading to oxidative tissue damage and inflammation. Phase 3 is where we have the opening of the interendothelial junction and migration of more inflammatory cells into the septal venules, including the macrophages, histiocytes, eosinophils. Phase 4 is when the macrophages secrete inflammatory cytokines, which stimulate the proliferation of more helper T cells. Now, phase 1 to 4 manifest clinically as lesions which are red, tender nodules, poorly defined, varying in size from 2 to 6 centimeters, usually on the shins. This can progress through to phase 5, where the T-alpha-1 cells secrete more cytokines, leading to further release of Th1 cytokines, mediating the immune complex deposition in the septal venules of the subcutaneous fat. This is an example of a type 4 delayed hypersensitivity reaction. In phase 5, as we know, clinically the lesions become tense, hard, and painful. They then change in color into bluish and livid by the second week. And phase 6, the final phase, is where we have activated macrophages producing hydrolytic enzymes and transform into the beautiful multinucleated giant cells. This is something we call Meschker's radial granulomata. These consist of small, well-defined aggregations of small histiocytes arranged radially around a small cleft of variable shape in the septal venules of subcut fat. Clinically, these lesions become fluctuant as an abscess but do not ulcerate. Lesions eventually fade to a yellowish color. My friends, allow me to share from the Bible. Matthew chapter 5 verse 28, Jesus himself says, "But I tell you that anyone who even looks at a woman lustfully has already committed adultery with her in his heart." So we see that whenever Jesus spoke about such things, it represents an amplification of what was in the Old Covenant. In the Old Testament, one of the 10 Commandments is, "You shall not commit adultery." But Jesus goes one step further and says, "You should not even lust after a woman in your heart." So what was external in the Old is now internal in the New. Not that the Old has been abolished in terms of the commandments, but Jesus has amplified it. And we can only do this by the indwelling power of the Holy Spirit that gives us divine enablement, which is grace, and helps us to overcome, especially in the area of sexual temptation. God bless you. Here are my references. I'll see you soon. Take care.